Are you considering having a myomectomy, also known as a fibroid surgery? Have you just had one and are thinking, what can I do to help my body prevent the return of fibroids or future complications? These are all questions that Black women wrestle with as they experience fibroids. Up to 90% of Black women experience fibroids by age 50. Not only do we experience them more frequently, but in larger number, more symptomatic, more having advanced fibroid disease, right? Well, we posted about it earlier this week and the response was incredible. My good friend, physician partner, Dr. P is here to join me for a conversation today. And our topic is before fibroid surgery, 5 questions that you need to ask. So before we jump in, take a moment now to share this with all your sisters, all your girlfriend network, all of the women that you love and you care for. Share it now, because even if they don't need it right now, they're probably going to need it soon, unfortunately, right? So let me officially welcome you to Detox Living, where we bring you tips, truths, and testimonials to power your toxic-free living. I am your host, Coach Gessie. I am a fibroid survivor myself, turned health activist and founder of the DetoxNow.com, a holistic health platform and provider of education and supplements that help you combat the chronic disease, the reproductive issues such as fibroids and more, as well as obesity and more that lead to lower life expectancy rates. So join me in welcoming my guest. Woo! It's one of those weeks. Yep. One of those weeks. You know, I have to first start out by saying thank you to everyone, because I posted this week about the fact that I'm not in my regular location because I had to stop and drop everything to come and advocate for my cousin who is literally fighting for his life, 35-year-old, and literally was being just left to deteriorate and die. And unfortunately, there were so many things that were negligent, were not being done. And this is why we do this, right? Because we want to make sure that we equip everyone with the information they need to have the best health outcomes that they can have. So thank you for your prayers, y'all. Thank you for your encouraging words. Please do not stop. Please continue to pray, because it's at this point now, because of the negligence that was at play, we are really in need of a miracle that is like, a crazy faith miracle. So, so welcome, my friend. It's good to have a conversation with you. It's Fibroids Awareness Month. I could not have a conversation with you because we do this to change the outcomes, right? To change the experiences. And I know you had a rough day, a rough week. So I want to just tell you thank you, because you don't do it for the money. You don't do it for fame. You don't do it so the industry will know your name. You do it because of your passion, your commitment to actually see change happen and for people to have better outcomes. So thank you.
Thank you for having me. Been a week.
Yeah. So let's jump into it, right? You posted it was 4 questions. I was like, man, I want to add one to it because I feel it's really important for us to equip people. What I've learned in this scenario, advocacy, everybody needs an advocate. And number one, you need to be your number one advocate, right? And how can you be that proper advocate if you don't have the right information? You don't know the right questions to ask, right? You don't know what your rights are, right? Because many people just take what is told to them at face value because they don't know that they can and deserve better, right? So equipping our community with the questions they need and the information they need is number one, It's really critical, right? So what I'd like to do is in this conversation, real simple, is to unpack those questions, why they're so important, and what kind of answers they should be looking for, right? Simple conversation. And the first, question was, this is for people who are thinking about having fibroid surgery, right? Preparing for fibroid surgery. And, want to assess who they're talking to. They want to assess whether or not this is a partner. And I say partner because your physician should be your partner on your journey of healing, right? That they can trust with their life, their health, right? So the first question was, what is your experience with fibroid surgery and how many have you done?
Sure.
Why is that important? And what kind of answer should we be looking for?
So you want someone with a vast amount of surgical experience that at least does, I would say, to be fair, probably optimally at least 25 to 30 cases per year of fibroid surgeries. That's a fair number. That means they at least
that sounds like a low number.
It isn't. I mean, because even myself, like, I do a lot of fibroid surgery. You're not gonna find someone that does like fibroid surgery like me. So and for what I do, it's a lot. Like for me to do, like yesterday, I had 2 fibroid surgeries, like, and it was the entire day. So it was, first case was like 6 hours. The second case was like another 5-6 hours. Like that's the entire day. It's not a lot of people that's going to do that extensively. Right. You only got about maybe 2 or 3 of those a week.
But you don't think one a week doesn't sound fair?
Yeah. So, I mean, one a week would average out to 48 for the year, and that's an upper limit of experience. So I would say conservatively at least 25 to 30 myomectomies a year is fair. And and then that's it. Just and have some years behind it, have like, I've I trained and I did XYZ, and then I've been, practicing, 6-7 years, and I've been doing myomectomies as a passion of mine. So that's the answer you want to hear from that question.
Okay. So something you said earlier, I do want to touch on, is that just because you're an OBGYN doesn't mean that surgeries are your specialty.
Correct.
Right? That's very important to understand, that if they can be more someone who does a lot more deliveries, just general clinical care, but not necessarily that surgery is their specialty. You want someone that surgery is their specialty and their passion.
I'll take y'all a little bit further behind the curtain. So OBGYN residencies are 4 years. An overwhelming majority of OBGYN residencies are OB heavy, meaning that you get a lot of deliveries, you do a lot of prenatal stuff, and you do minimal GYN. So you have a lot. I would honestly say probably, I don't know, I'm a
ballpark
regret saying that, but you have a lot of OBGYNs that are really not good surgeons. Mm-hmm. And I hate to say it about my field, but that's just it.
Because they're spending more of their time doing deliveries.
And that's what they were trained doing. They just did not have a lot of training for surgery. And then you have people that really specialize in it, that did extra training, that went or did minimally invasive training for it or what have you. Like, those people have more experience. You kind of want to hear like what the experience was, their residency training, their training after, like their passion for specific surgery. You can ask another fair question is like, what is your OB to GYN volume?
Right? I like that question.
Your OB, anything less than 50-50, they're probably not strong surgically. If they have a very top heavy OB, if they're like 60-40, 70-30, that means they're doing a lot of obstetrics and they're not doing a lot of cases. So that's really how you could ask the question without being overly offensive. Just ask them, what's the OB to GYN ratio in your practice? Perfect question. And they should not get upset with asking that, what you asking that.
So what about the question about whether, and I mean, let's contextualize that for if they're doing, robotic, or if they're doing, the hysteroscopic approach,
Sure.
just specialty specifically. Wouldn't you use that same framework? Like, what is your ratio? You're doing those kinds, if that's what you're looking for.
Yeah, I mean, but like,
Probably
so, so,
less.
sometimes that's a little difficult if they, you take what's going through the door, so it's hard to say like
But if
what's,
you're a specialist with minimally invasive, then
yeah,
you would get more of those cases, right?
yeah, you would, but they should be open to talk. Like if you ask me, like I'll just like talk about it. Like I'll get specific. I'll start showing you pictures. Like, what I mean? It's like I can, get into it. Like don't if someone's offended with you asking their experience or their expertise or whatever, that's a red
That's a
flag.
red flag. That's just a red
Yeah,
flag, period, right? Because
yeah,
too many of us are dealing with misdiagnosis or botched up surgeries, or, unfortunately fatalities, unfortunately, because of the fact that we're so tiptoeing around what needs to be seen as a peer level relationship, right? Because I always talk
absolutely.
about how when you are partnering with a physician for your health, there are two experts in the room. Two experts are you and the physician. The physician is hopefully the expert on fibroids, and you should be the expert on your body, yourself. And that means both expertise need to be respected and treated in that way. And if it's not, then that is absolutely an indicator. They will dismiss your pain. They will dismiss what you have to say in terms of you saying something is wrong, right? And that means that you can end up in very negative outcomes with those kind of realities. So you want those red flags. So I'm like, trigger the flag. Like, okay, if I've offended you, then that tells me that you don't really understand the scenario out here for Black women. You don't understand that we're fighting for our lives, right? And if you turn it around and you're not trying to protect and support that, then that's an indicator for me. All right, question number 2. Well, hold on, let me see people. Yes, somebody. I was told I will need a C-section as well because it's a saver for rupture. Okay, I didn't see the first part of that question. Let me go to question 2. You can scroll through if you want. What is your approach to removing large fibroids, horizontal or vertical? I know this is one of your favorites.
So for me, I scale back a little bit because I don't think it's fair for me to always say that like horizontal is absolutely the only way you can do it. I think it's the only way you should, but to that point, there are certain cases where
Mhm.
it is you really have to be very, very skilled to do a horizontal incision. Right. So
Mhm.
I would say and it's not an indictment on someone if you got a 15-pound fibroid uterus and they say, hey, I'm just not comfortable doing it horizontal, but
Mhm.
that doesn't make them a bad surgeon. I literally had to just do it and just keep doing it and perfect stuff or what have you.
Right.
And you got to
That's how
step
you're
out.
able to do it.
Right. And that's
Mhm.
how I was able to do it. You got to step out of a comfort zone.
Mhm.
So I would not say that, hey, if anybody says a vertical is never the right thing, that's going extreme.
Okay.
For me, yes, but if you're asking a doctor, that's not a deal breaker.
Mhm.
What I would be looking for from them would be to say, hey, I care about your cosmetic appearance. I care
Mhm.
about your healing. I care about your pain. I care about those things. I'm going to do an incision that makes that fits all of those things. And personally, I have to just put myself into it, and I just say, hey, even though I'm inconvenienced by doing this incision, the convenience is to you.
Mhm.
So you have to have a doctor that is
And it's a
going to
long-term impact. It's
absolutely,
long-term impact. Once that is cut vertical,
absolutely.
there's a long-term
It's a lot.
impact of scarring, period, and the risk associated with, small bowel obstructions that can come from scar tissue. Again, it's more scar tissue that you have to deal
Yeah,
with, period.
yeah.
And
So,
it's
so
more around more organs
sure,
because now it's a longer one,
sure.
right?
I mean, and every time, and to the point of vertical incision, the reason I'm so to that point against vertical incisions for anything is because the healing process, the pain, it's
Mhm.
different, right? Every time you get up
Absolutely.
from a seated position, you're putting stress. So it's called the Langerhans lines of your skin. They
Mhm.
run this way. right? So if you try it, when you get up,
Literally opposite.
everything folds this way. So when you
Hmm.
cut this way and you try to get up, everything pushes out this way. So
Everything.
it's impeding healing anytime you get up or sit down or you move, you cough or whatever. It's really putting tension and pressure. That's why a lot of those incisions, keloid. That's why a lot of those incisions really have thickened scar because it takes a lot for them to heal.
And
So when you talk,
are more likely to form obstruction because of the fact that there is so much more. I remember the first time I formed a bowel obstruction. It was the vertical. It wasn't the horizontal one. It was
but
the vertical one.
to that point, it's not so much the skin incision because the skin incision is
No,
not
it's not
what's
the
doing it.
skin. It's inside.
It's what's happening inside. And to
Absolutely.
that point, you're asking you have to ask your doctor specifically their approach to surgery. Like, how
Hmm.
meticulous are you when you go in there dissecting tissues, when you're putting things back together again? Like, what's your approach? They can walk you through things or what have you. Like me personally, what I tell people, like for C-sections, like when they do a C-section, it's one of the most crazy morbid things you ever see. It basically take these scissors, cut, and you're cutting fascia, you cut muscle, you cut. They're worried about speed. I tell my residents all the time, never do this. If you wouldn't do that to your mama, don't do that to nobody else. And when they get down to the peritoneum, which is underneath the fascia, and that's the last layer of tissue before you get to your abdomen, they literally take one finger. Somebody stand on one side, take one finger. Somebody tells the other side will take another finger, and they rip open your belly. So I am so like anti that, but I train that way. I learned that way. That's in residency. That's how I learned until like I got on my own. It was like, this ain't right. I cannot, I'm never doing this. So to that point, a seasoned OBGYN will say, hey, I am very meticulous. I'll walk you through the steps of how I perform surgery, how I approach the fibroids, how meticulous I am with putting things back together again. Another issue is, diastasis recti. So
that was the next thing. You literally took the words out of my mouth because that was next.
Right. So like when
explain what that is first. Explain what that
so
is
when
first.
you have the abdominal, well, diastasis recti is basically like a herniation of the muscle.
Right.
So
it doesn't
when
close properly.
when you have a hernia, when a hernia is really like a breach in a protective layer. So if you see somebody that has a belly button hernia, that means the skin that's underneath the skin called the fascia, there's a hole in the fascia and it's allowing the bowel and everything up underneath to kind of push through. Well, that same thing can happen with the muscle because the muscle is another layer of your abdomen. So when you go and do C-sections, you got skin, fat, fascia, muscle, then peritoneum, right? You got to get through all of those layers just to get on the inside where your belly is at. So your muscles sit in a vertical plane like this in your belly, like this. And so when you go into your abdomen, you have to separate them to get inside. Diastasis recti is when they separate and they never come back together. Right. So the things that are inside your bowel and everything can protrude through your muscle because it's not together. When they do C-sections, this is how we're taught. All OBGYNs are taught this way. You go in, you cut, you do the fascia, you separate the muscles, you go through the peritoneum, you go in, you pull the baby out, and you literally just close the fascia, close the skin. You don't close the muscle, you don't close the peritoneum. What that does is that this is what we taught. So what happens is it's like, yes, some people will heal and that muscle will come back together. But some women, that muscle really does not come back together. It stays kind of apart and it can herniate. That's what diastasis recti is. Now, some things can happen to where diastasis can happen without pregnancy. So don't always think that it's all from pregnant women. So some women have diastasis and are not pregnant. But a lot of times, especially with C-sections, it is jump started by going through separating the muscle and not putting the muscle back together again. And it basically allows the contents from underneath to kind of protrude through. And that's what plastic surgeons get paid for. I got plastic surgeon friends all the time that are all over. They repair diastasis. They go in, make that incision back, open everything, cut it up, do the liposuction, get the fat out. And then now they put permanent suture to close the muscle back. Whereas if your doctor that went in there doing whatever abdominal surgery you had would have done that, the chances of you having diastasis in the future would decrease. So
Wow.
that's more stuff. I got surgery stuff that happens with OBGYNs all day. I teach all over the country. I see it. It's cringeworthy stuff. I see cringeworthy stuff happen all the time. Even with my own personal residents that I know that like other doctors are teaching them and the stuff, they come into my surgeries. I'm like, don't you ever in your lifetime do what you just learned here,
Wow.
because it's not gonna
Wow.
work. So but they're not alone. It happens everywhere. It's a travesty, and that's what people don't get. Like there's levels to surgery, especially when it comes to OBGYNs, because we just have very different levels of training and experience, and you have to really sift through it to find out what that level is and what their approach, because if they don't give a shit and they are just really just going in there and trying to get quick, they're not closing stuff, they just going in, just trying to do it as quick as possible and get you up out of there.
Have you seen this case of say it again, diastasis recti?
Diastasis recti.
Where it came as a result of advanced fibroid disease and not even a surgery.
Yep.
Talk about how that happens.
Because the muscles literally, they sit like this, like you have like a right side, left side, and they connect into the midline. So it's not like super glue where they're connected. Once you start pushing out, they start to naturally separate, right? So if you got someone that has like advanced fibroid disease with a protruding abdomen that's protruding the muscle and separating them like that for an extensive period of time, when that fibroid stuff is removed, it usually comes back, but they still may have some separation. It doesn't happen to everybody, but I see it like a lot of the some of the patients, like with the larger fibroids, I see have diastasis. I give them a solid. I'll repair it when I'm doing it.
So you'll see it in the surgery. You would see it in the surgery.
I can see it outside of it. So you can see it outside of it. So you know that they have it.
Okay.
So when I'm in there, I make sure that I repair it. And if they have, and a lot of those patients can also have umbilical hernias, like when you have like extensive protrusion, the fascia or that other layer of skin that's up underneath, that's around your belly button, it's at the weakest point at your belly button. So when you protrude it out like that, it can expand, and they have a hernia there where bowel will push through their belly button. And so I'll repair that too. So you want to ask people about that. Like if you see something wrong,
so I was going to ask, right. That's what I was going to say. That sounds like another question.
Correct.
Which is, what have you encountered diastasis recti or umbilical hernias during a fibroid surgery, and what do you do? Right. Yeah. That gives us a little bit more insight to
absolutely
the work ethic of and the level of excellence and the commitment to excellence of the physician. Right. So I like that question. All right.
So when I put them questions out, Ariel, who's on here, it was my social media manager. She took it from like a live that I was just talking just off the top of my head. Mm-hmm. So it's not super comprehensive. She took all of the points and
still
just,
great.
Made bullets. So like this is good to get me to talking about it, because it's stuff that I don't even like think to talk about. But since people watching, here you go.
Yeah, I love it. Thank you. Someone asked, can having a UAE procedure onset early menopause? Oh gosh, you froze again. Oh, there you are.
Yeah. I'm sorry. No, that was my daughter calling me. I just got to call her back.
Oh, phone came in. Okay, all right.
Yes. Yeah,
so if you want, we can come back, because that's a UAE conversation that might take us somewhere else.
These UAE.
No.
Boy, I wish I could have a T-shirt and say,
"Don't do it."
My answer is no. UAE,
no. UAE, no. Okay. So what is your approach to removing large fibroids? We said that, right? What is your conversion rate? How many times have you had to convert a myomectomy into a hysterectomy? And similarly, how many times? Okay, that's yours, and that's great. Shout out to you.
I will say, listen. So to that point, well, I won't say that. So 2 cases that I've had in my history, I did have to convert to hysterectomy because they were cancer cases. Mm-hmm. So that is. So I can't
that's
say
a requirement. There's nothing you can do about that.
That's something different. Now, this week, it's always, when I had these conversations, there's always something that just happened. Literally yesterday, I was thinking Tuesday. No, yesterday, I had a patient that, for the first time, it was so bad that I actually had to call her husband.
Wow.
And just say, hey, this is a lot. She flew up to see me,
Wow.
planned for it or what have you. I didn't anticipate what I saw. And I did something for the first time ever in my life. Um, and well, once I called him, and of course, he was like, I'm not making that decision. Go ahead and save it. It was really, really damaged. The fibroid had completely obliterated her endometrium. So the fibroid was inside of her uterus, and it was soft. It had started. It was. It had started to die. There was some
Degenerate.
areas of fibroid degenerate. Forget my word.
Mm-hmm.
So it was starting to degenerate, and it meshed into her endometrial cavity. So when I pulled the fibroid out and I pulled it out, it literally pulled out a good 80% of her endometrial cavity, which was still stuck to the fibroid. And not only was it just stuck, because if it's normally just stuck, I can kind of peel out. It was like just mush. It was all meshed together. So it was like you couldn't really tell what was endometrial tissue or what was fibroid. So I'm just looking at there with just a uterus with no cavity and this degenerated fibroid that had cavity all over it. So I was like, and then she had adenomyosis as well too. So I was correct. There's just a lot going on. But I promised her, I'm a man of my word. And I told her, if you wake up without a uterus, that means I had to save your life. This was not a life-saving thing. This was a decision thing.
Mm-hmm.
And so I called her husband. Her husband was like, save it. Just let her make the decision. I said, okay. So that meant what I had to do at that point was basically go and get as much of that healthy endometrial tissue off of the fibroid and harvest it. So I had to harvest it. So I had to really just kind of take these small scissors and just kind of cut all of the bad fibroid tissue off of that layer of the endometrium till I got a nice clear plane. And I had like puzzle pieces. I had like about 4 or 5 pieces of endometrium. I had to sit there and just like sew them and put them back together again until I recreated an endometrial cavity out of that tissue and stack, attaching them back down. And so it was like, I took video of it. It is like, I was like, dude, this is crazy. Like, if she has no periods and get pregnant after that, like, there needs to be like a book written. Like, it's like amazing. I've never done it. It's basically like an endometrial transplant with her own endometrium. So that was yesterday.
That's incredible. In that case, and you thought through creatively, you spoke to her family about it, all the things that are necessary. In that case, she may not be able to carry because we don't know what her the sufficiency of her, but she can do IVF and get the eggs.
She definitely can do that. She definitely can do that. But more importantly, I mean, to her point, like I made a promise to her, and though it took hours of my time in my day, if I promise her I'm gonna do something, I'm gonna do it. And let her make a decision.
Let her make the decision.
If at the end of the day she has to take it out, then so be it. But I wanted her to be able to make that decision and not me. So,
what are the risks in that case to her? Like, what are the risks?
She has a lot. I mean, honestly,
a lot of scarring.
I think there's scarring, a condition called Asherman syndrome, where she has scar tissue within her endometrial cavity. Very abnormal menstrual cycles or abnormal bleeding. I'm very curious to see what her menstrual cycles are going to look like. She does have adenomyosis, so that's going to be a contributory factor for her pain and bleeding. So
you want to tell them what adenomyosis is?
Sure. Age of the patient, she is 44 or 43 or 44, one or the other. So no kids and really wants to have a child, but. So
adenomyosis is like
adenomyosis
and fibroids.
Sure. So adenomyosis is when the lining of the uterus grows into the muscle of the uterus. Yeah, people like it's weird. You got pictures of the uterus just readily available. But yeah, so when this lining of the uterus, it grows into the actual muscle of the uterus, and it makes it a thick, boggy tissue of the uterus. And the problem is it's responsive to hormones. So it can be very painful. It can cause you to have very abnormal bleeding.
Similar to endometriosis. Similar to endometriosis.
Similar. Yeah.
that
Similar,
lining
but to the
forms
point,
lesions.
that endometriosis, it has some very effective treatments.
Mhm.
Adenomyosis really doesn't. There's really no truly effective treatments. You can help with
None.
some of the
Okay.
symptoms, but there's really nothing that's effective with adenomyosis.
Okay.
Yes, you
Say,
can. You can still carry a baby with that. Yes, you can.
with you mean adenomyosis or with what
You
happened
can.
with the patient?
You can. With we'll see about her. As
Right.
far as carrying, I'm not God. I just
I
do, what God tell
know,
me to
brother.
do.
I know.
We'll see where it goes. I never say, and that's another thing. Nobody should ever say you can't get pregnant or you
That's right.
cannot. Like we're not God.
Mhm.
We just say, hey, it's unlikely. It may not happen how you want
Mhm.
to or what have you, but I don't speak in definitives with people.
Yeah, a lot of Black women got their uteruses taken away because of medical racism. That's
Facts.
very true. Somebody said that.
Facts.
Facts, facts. What should the conversion rate be? Because we said that question, but I didn't. You said we talked about
Minimal.
yours being zero. So
Minimal. They should be
what are some numbers?
minimal. They should say, hey,
Under
you know,
5?
yeah, just say, hey, I can, they should be able to recount the cases in which they had to convert and do a hysterectomy with when they were set to do a myomectomy. They should be able to say, hey, yeah, I haven't had many, but there was
Very
this one
specific
case, or there was this
cases.
one case, very specific cases where it sticks out in their mind. If they say like, yeah, 20% of the time, yeah, I may have to take a use, like go for the door. That means
Mm.
they're not skilled at what they're doing. And that could be bad news for you.
What are reasons that people typically, I know what they say, so I've heard the reason that we've had to convert the myomectomy into hysterectomy is because there were just too many fibroids and we just,
That's not,
that I've heard that.
yeah,
So
that's right.
let's
Yeah,
talk about what are excuses that they hear. So that's one of them. What's the
sure,
reality though? Like what's the real reason why they way would convert them? They don't have the
sure.
skill
So,
level. You just mentioned that.
sure. So there's a very, very fine line in medicine with personal opinions and decisions and actual medical necessities, right?
Okay.
So a reason like you have too many fibroids, that's an opinion
Mm.
because you may have too many fibroids for your experience that you've seen.
Mhm.
I just removed 133 fibroids out of women that came from the East Coast. Some people, a lot of GYNs have never seen that many fibroids before. But
Mhm.
an opinion would be that person needs to have their uterus removed.
Mhm.
But that opinion
That's an
is
opinion.
precipitated. That's an opinion precipitated on your experience.
Mhm.
Whereas the true reasons to do a hysterectomy are life-saving things. Your uterus is bleeding so much to where it's getting dangerous and it's not, I can't stop the bleeding. Like, so now it's your life or your uterus. Your life needs to win. Hysterectomy needs to happen. It's never like she's not going to be able to get pregnant with this uterus. I've had countless cases of, in my mind, I'm saying she's not going to be able to get pregnant with this, but it's not my decision to say, I need to remove this. That is still her, you guys' right to say, hey, if it's just not going to happen, it's going to be on my terms if it's not happening, not because of you. So the opinion of should a hysterectomy be performed should never be, it should always be, this is a medical necessity because I'm fearful of complications. I'm fearful of your life. I'm fearful of that. That's the reasons myomectomy should be converted to hysterectomy.
I love that answer, and I fully endorse that response because that's it. It really should be because it's life saving. It's required to save your life. What you don't want is for it to be required to save your life because the doctor is not skilled at doing it otherwise, right? And that's why the other questions are important to help us get to the level of the skill of the physician, right? You have something you want to say?
No, I was just saying facts. I'm agreeing with you.
Okay. Do you, another favorite one, do you remove all the fibroids no matter what size?
Every single one of them, no matter what. Every single one of them. So I won't. Well, no, I've always thought that. So I could safely say that, throughout my career that I've always had that idea and mentality. I
Mhm.
will say that I've evolved with my aggression or steadfastness of going after them. You know, Now, like if you talk to me maybe 10 years ago, I would like feel around and I feel them and, I don't feel anything. We're done. Now I'm like OCD meticulous to like feel, make sure, let my assistant feel to make sure that I'm not okay, walk away for a second, let my mind mentally clear, come back and then feel again to make sure I got every single thing. Now I'm OCD about it because when I tell somebody confidently that you're not going to come back to me for fibroid surgery, I'm saying that with the confidence of this common sense fact that for most women, if you remove fibroids, if you remove them all, you don't have the ovarian life still left in your lifetime for you to regenerate a new fibroid and for that fibroid to grow large enough to actually give you a problem. So for my patients, I'm like, listen, if we perform a surgery and I do a myomectomy, you're 38, and then you do a scan when you're 45 and it says, oh, you got a 2 centimeter fibroid. I don't give a shit. You shouldn't care. I don't care because we don't have to operate. It's just there. Okay. So it's not to say, oh, it's a fibroid came back. Did a fibroid come back to the point where it's giving you pain, bleeding, and issues? And if you remove them all, the chances of them regenerating and starting new and grow big enough to give you a problem are nil to none. But half of my patients have had myomectomies.
In your childbearing years where they're actually growing more. So let's break that down some more. Number one.
Hold on, let me finish. Let me finish this one thing. So half of my patients have had myomectomies already, whether laparoscopic or open, and they come back to me now for another surgery. I saw a lady today coming back scheduled for another surgery.
Not my
surgery, not from me, but not from me, just a new patient that flew in from Houston to come see me. But to that point is that the thought is my fibroids came back. They didn't come back. It's not that they came back. They left fibroids in you, and those fibroids just grew. If you're meticulous about getting them, the chances of them actually growing anew and coming back are nil to none. But okay, I'm sorry. Go ahead.
A couple of points, important points there. Number one is that someone asked, what about the physician that says, well, there are some fibroids that will cause infertility if I remove them? That's one question. The second one is, what about there are some fibroids that where they are, it's more dangerous to get them? So the two important follow-up questions.
Sure.
And then the third thing is something that I wanted to just amplify the fact that most fibroids, because I've had women say, I just had a myomectomy 6 months ago and they're returning. Or really, I would say probably 90% of cases, and again, this is just based on what we, just assessment, just are because fibroids were left. Right? They were left. 99% cases are because fibroids were left, little small ones. I had a myomectomy in July of 2010 and underwent IVF, which was my 5th IVF cycle in November of that year. And it was January, sorry. I got pregnant with my daughter, and in 21 weeks, right? So back it up, 21 weeks was June-ish, so May, June-ish. Bottom line is fibroids were now taking the blood supply away from my daughter because they were there and they were growing. Well, pregnancy does grow, the hormone is that environment for them to grow, exponentially. But the point is that they were there. So 3 questions, let's ask her.
I want to say something very controversial. People are not going to like this, but I'm going to say it anyway. If you I don't care. You know me. I don't care. So
come on with it.
If you had a laparoscopic or robotic myomectomy, there's an overwhelming chance that you still have fibroids. I'll say it again. If you had a laparoscopic or robotic myomectomy, there's an overwhelming high chance that you still have fibroids because I stopped doing it about 5 or 6 years ago. I say this all the time, and I argue with actual surgeons about this. And like, oh, if you do an MRI, and I said, I cannot tell you the last surgery that I performed where whatever was on the MRI or ultrasound and how many fibroids they said was the number of fibroids I pulled out. it's
Right.
always more.
Way more.
Always, it's always double. I can't tell you the
Always.
last time I pulled out less than double digit fibroids. You can't find an ultrasound or MRI that has double digits.
Because
So that
the
means
little ones are never seen. They're
they're
never
never
counted, the little ones.
they're not mentioned. They're not going to be mentioned on an ultrasound. And if you got like my patient from last week that had 130 some odd fibroids, you're never going to see or talk about all of those. And to that point, I'll go back to my analogy. It's like a T-bone steak, and you just hide marbles, peas, avocados, golf ball. You put all of these masses, 100 of them, and hide them into the steak, and you have to remove all of them with a fork and a knife. You can't touch it, just a fork and a knife. You're going to remove the avocados. You're going to remove the golf balls. You're going to remove, some of those marbles. I promise you, there will be some peas and marbles that will still be in there because you have to feel it. The only way you could get them all is to feel it. Only possible way. And so if you had those things and you got small fibroids, they're not going to be removed with somebody seeing it because they can't be seen. That's number one. Back to your question as far as like location of fibroids.
Oh, wait,
Yeah.
let's go back to that one for a second. What about people who may say, well, I would prefer use a minimally invasive approach so that I can protect my body from scarring, from having to have that major healing, and maybe work through lifestyle changes to tackle those that are really small. That is still an approach somebody may choose to go through.
It's true. It's true. But at the same token, once you start removing fibroids, you're going to have a C-section.
If you did it robotically,
Absolutely.
Oh, why?
You are now obligated for C-section.
I mean, there are cases, let's be clear. There are cases where women, and I just had a client 2 weeks ago who she was told she would not be, after a myomectomy, she wouldn't be able to. No, she had fibroids. She didn't have a myomectomy. She had fibroids, and she was told she would be. So she didn't have a surgery. She did have fibroids, and she delivered, no problem. But go ahead. So you're saying two different things. I just remember.
Totally different story.
You're saying even if you
when you have a myomectomy and you remove it, look at it this way. I'm always about analogies. So
what about Assessa? Somebody just said Assessa. That's different.
Different is not changing the structure of the uterus. So think about it this way. So if you have a house, you have a brick house, and systematically you just started to remove maybe 12, 13, 14 of the bricks in the foundation, right? Your house is still going to be fine. If I go take 14 bricks out of my house right now, it's still going to be structurally intact.
The integrity of the uterus.
When a tornado comes here, right? My house is in danger because once it hits, it is going to fall at the weakest point. When you are delivering a child, you are banking on this 7 or 8 pound mass fitting through a hole this big, putting 200 pounds of pressure into fitting that through that hole. And either A, that hole is going to open up and that 7 or 8 pound mass is going to fit through that hole, or the pressure is going to be so large that the weakness in that cavity or that uterus is going to open. You don't 5 to 6% of the time that is the case when you have major uterine surgery. You do not do anything 5 to 6% of the time. You right now say you're going to hop in a plane and you're going to fly off to Jamaica, and 5 to 6% of the chance you have a 5 to 6% chance that plane is not going to make it. I guarantee you don't get on that plane. If you had a 5 to 6% chance right now, if you go into the grocery store and your car was not going to make it, I guarantee you would Instacart. You would never do that. You would not take a 5 to 6% chance risk of dying for anything. Pregnancy and delivering naturally is the same thing. You're not going to do that. And
okay.
If an OBGYN is smart and cares about his life and his license, they would not allow you to do that because they're putting.
Yeah, no, I don't think any of them. But the Assessa is different because they're not cutting. The Assessa is different. You're not being cut open. It's sonogram guided burning of, the actual fibroids is very different. There's no cutting involved.
No UFEs. I am totally against UFEs. I am 1000% against UFEs. If you go to my page, I did a whole thing on it. Yeah, I did that. There's a whole video explaining like why I don't agree with UFEs.
Okay, so going back, so the person who says fertility, they may say, that I can, because we kind of we conflated things. So going back, the first thing was, hey, I don't want to remove all the I may not remove all the fibroids, because what if one is going to affect your fertility if I remove it?
So what are the chances of, if that fibroid is significantly pushing into the cavity, what are your chances of getting pregnant anyway?
Yeah.
So you always ask, people ask for side effects. Just like I had a patient today. That's always recency. I had a patient today that's bleeding horribly. Fibroids, so surgery's not until November. I gave her my Fibroid to take. She said, you know what, doc, I just read the back and there's so many side effects, and I just decided not to take it. That's fine. You're bleeding uncontrollably. The side effect, what is the side effect of that?
Heart attack, dying.
Right, correct. And then she goes on to say, yeah, but my doctor wants me to try Lupron. I tried Lupron in the past, and I'm going to try Lupron. It's education, people. Like it's education. Lupron is a more extensive drug than Fibroid.
Yeah.
So if you don't know about something, like be thoroughly explained about these things, before making decisions.
Okay, so that was the fertility question. What about save your life? Like, if I can't get all the fibroids because it could be dangerous for you. That's common response.
The skill level.
So if they say that, that's an indicator.
It's the skill level. You should be able to control blood supply. If it comes back down to blood supply. The only reason your life will be in peril would be because you're losing so much blood and they don't have enough time, and it's unsafe to remove them because now you're losing so much blood. Other than that, there's not a reason why you should not be able to remove them all.
Someone asked, can the size of the fibroid determine if you can have a myomectomy or not?
I would say the appropriateness of a myomectomy is somewhat depending on size. I would not recommend someone with extremely small fibroids necessarily getting a myomectomy unless they are like advanced in their suffering, advanced in their age. So even with suffering, there are things that you could do to kind of treat this. Mm-hmm. But if you are now 41, 42, you are at the end of your rope for fertility, and you don't have a lot of time to really try some of these lesser methods, and you need to give the best chance, go through IVF and need it. There is no tomorrow. There is no like, oh yeah, these are too small. Yeah. It's like, you got to give yourself the best chance.
Agreed.
So it's everybody. Agreed. Every situation is a little different.
Agreed. Okay. So what are your recommendations for prevention after surgery? I added that one.
Go see Coach Gessie. No, I say, it's, for me, I tell my patients, I say, listen, it is a lifestyle change, right? Absolutely. It is, you are what you eat. I love that. I love that documentary. I changed my life from that documentary. It just is what it is. The reason why we have, people healthy people in their late 30s, early 40s that are dying from colon cancer now, and they were not doing that 50, 60 years ago, is our food.
Lifestyle.
It's so much stuff that they're putting in our food, and what we're doing, it doesn't stop there. It doesn't stop with fibroids. It doesn't stop with hypertension. It doesn't stop with diabetes. Like, all of these things from a health perspective have a lot to do with what we put in our body. So living a healthier life is the very first and foremost thing that you can do for prevention. Vitamin D is another important, making sure your vitamins are up to par. There are studies right now.
High levels.
That are showing that vitamin D deficiency does, show kind of like a gateway to fibroid formation and things, especially for women that have genes that are coding for fibroids. So making sure vitamin D levels are adequate, vitamin levels are adequate, which all stems from nutrition, and making sure your diet and what you put in your body is good stuff. That's the overall best thing that you can do to make sure it's very critical. Very critical.
So we're actually, when you talk about all of those factors, lifestyle, I love that you said, what we're dealing with now is not the same thing as the generations before us, because I say this all the time, that it is literally legal to poison us in the United States. All right. Because if you take a box of oatmeal, and I use it because I've seen it, a box of Quaker oatmeal in the US, and you put it side by side with a box of the same exact Quaker oatmeal in London or France or Canada, the one in the US will have like 29, 30 ingredients. The one in Canada or France, Paris or London, etc., will have like 9. And the reason is because so many of the ingredients that are used in our foods are illegal outside of the United States. Facts. So, and then on top of that, 78% of the products that are marketed to Black women, all right, have harmful ingredients that are linked to carcinogens, hormone disruption, and reproductive damage. We're talking about everything from shampoo to the lotions, right, to the food that we're eating, the dry goods, as well as beauty products, right? So literally, that's why our End Fibroids program, or End Fibroids, we're doing a challenge, a 30-day challenge to walk with you. Dr. P is going to be on one of my sessions because we're going to dig into some more. I ain't tell you yet, but you already know. We already have it. But we're going to be doing some sessions literally each week for 30 days. We're going to be doing sessions to literally walk you through a 30-day challenge to see, hey, what can you do? What can you do, right? Specifically to tackle those things, everything from nutrition, because there are studies around foods that help support specifically, your body, helping your body an anti-inflammatory protocol, as well as supplements, as well as lifestyle changes, that are practices such as proper sleep, cold water therapy, the vitamin D we talked about, green tea, some more. There's so many things that we can do. And the reason we want to do them is so that it is about fibroids, but it's really not just about fibroids. It's also, there's a pandemic of overall toxicity in everything from, like we just said, colon cancer, getting them younger and younger, right, to other health issues. And it's because of the toxicity of our lifestyle. It's not that we are trying to live more toxic lifestyles than the generations before us. It's that the environment is just so much more toxic in terms of what we live in, right? Like it's just simple as that. So we literally have to be intentional. We have to be intentional. We have to take control of our lifestyles and say, all right, you know what? I got to be radical about my health because they're literally trying to poison me out here. I mean, simple as that. Like, it's crazy. It is crazy. It is. My cousin was diagnosed with stage 4 colon cancer. No, Jesus. Like 35 years old. No symptoms before.
That's
this.
Crazy.
You see what I'm saying?
I mean, this doesn't happen in 50, 60. Like our grandparents, like they weren't dying.
It happened to them.
They were dying differently. Like they were not, it's the stuff that they're putting in this stuff. That's why
That's why it's serious. It's serious, y'all.
Changed my life.
Nah.
And I knew it, but I had to actually see it and see them like actually do a study on it. I'm all on study-based stuff. Like once I saw it, I'm like,
now you see the study. So now you understand. I love me.
I love Yeah, you give me
gotta
ribeye,
love me
like
more.
a medium ribeye. Oh my God, I love it.
But you know what?
But it's not worth my life. It's not worth my life.
But if you are going to eat it, if you do grass fed and you do minimal compared to everything else that's on your plate, it means you can have the proper balance. You can have the proper balance.
Regenerative farms, like if you know where it's coming from, you can go to a regenerative farm where you know what they're doing.
So we're going to be talking about all of that on this challenge, everything. That means if you don't want to be vegan, we got a plan for you. If you just want to find out what you can do. So please join us. All right. Yeah. So Dr. P, I think we went through all the questions. I want to make sure I know we like to go through, I got to get back to the hospital. I've been living in the hospital with my family, right? Dealing with this. I don't want y'all.
Praying for you.
Yo, man. And we fighting for it. And then on top of that, the medical bias is literally just leaving you. All right. It's crazy. Yep. I think we answered all the questions, so I appreciate you, bruh, and we're definitely going to, somebody asked, are we going to post this? Absolutely. We
Absolutely.
always share it and save it. So we're about to do that. And, maybe we'll do a part 2 with more questions. So, post your questions in the comments if you have more of them. But I think the key thing is that you have the power. And the more we are empowered with what we can do with the right mindset of knowing what our rights are and what kind of level of skill, how you test for and find out and ensure that you're getting the best service, right? That it helps you overall to have better outcomes, period. All right?
Facts. Thanks, everybody.
Appreciate you, bruh. We'll talk offline.
Appreciate you. All right, for sure.
All right,
All right, everybody. Y'all be blessed.
Yes. So everybody, thank you so much for joining us today. We appreciate you. We appreciate just the opportunity to be a part of your life and your health and your healing. All right. If you have any questions, just comment fibroids and book a consult with Dr. P. Information on joining our free challenge, our 30-day free challenge, the End Fibroids 30-day group challenge, hosted by me and my friends, including, of course, nutritionist Nev, known as Dr. Amun, of course, Dr. P, and some others. And we'll send you all of the resources that we recommend for you. And also you can visit the detoxnow.com/end fibroids. That's where the challenge information is. But it's right on the homepage, the detoxnow.com. Not sure what you need? You could always take our quiz. And it'll direct you with what's recommended for you and how we can support you. But one thing I want you to know is that you deserve vibrant, thriving, and abundant health. Don't stand for anything less. And we are here to support you in experiencing and realizing that. Take care.